So again, back to methylation and ZDog MD. I don't get any of my prevention stuff from him. He's an intensivist, and actually, there's only a couple of his songs that I thought were somewhat entertaining. I don't watch it very much, but I noticed again, he said, like many docs, MTHFR is not real. Methylation is not real. It is real. It is significant. You start to see that when you get a little bit deeper into more of the subtleties of prevention. Also wanted to connect another dot, and you'll see how these connect in just a few minutes. AREDS, age-related eye disease. So let's get started on the, go back to folate for a second. When you go to medical school, about the only place you're going to hear about folate is with neural tube defects. These are well known. About 80 countries mandate supplementation with folic acid. They don't really focus on the subtleties of bioavailability of methylfolate versus folic acid. And that's what we're trying to prevent, spina bifida. There's another clinical problem that we see with folate that has to do with folate. It's a megaloblastic anemia. You see megalo meaning big, blastic meaning cells. So you get really big red cells. Both B12 and folate are used in terms of DNA and development of cells. So both of them, deficiencies of either one can cause what we call a megaloblastic anemia, an inappropriately developed red cell. And with any significant anemia, you can get fatigue, you get tired, you get short of breath because you're not transporting oxygen well enough. Causes of folate deficiency. Alcohol is probably the most common cause for middle-agers, but pregnancy is a significant cause of folate deficiency. The reason for that is, again, the pregnant mother, the child is in development and is there's a lot of DNA replication going on. And then, of course, dietary insufficiency. As we mentioned, there are differences between folate versus folic acid. Both of these, by the way, are vitamin B9. Folate's naturally occurring. It's an essential vitamin. Pardon that spelling. Oops. It's easily absorbed and metabolized. Folic acid is a synthetic. You find it in a lot of fortified foods. Again, there's some question about its bioavailability and some of the endocrine impacts of it. Now let's jump over to methylation, and we'll see why, how we connect those dots in just a couple of minutes. Why is methylation an issue, and what is it? First of all, there's an enzyme called methylene tetrahydrofolate reductase. Don't worry about remembering that. MTHFR. That's when you hear that, you'll hear the name. That's the enzyme they're talking about. That enzyme is used in methylation. Now, why is methylation important? Well, it's used by our body in terms of making some important components of both DNA and proteins, amino acids. But methylation is also the way that we deal with oxidation. Remember, oxidation is a big deal for our body. We've been taking the mitochondrial theory of aging has been the reigning theory of aging up until the information theory came up recently. And the mitochondrial theory of aging has to do with the fact that mitochondria are like furnaces. They oxidize. That is their purpose. Oxidation is linked with carrying oxygen. So we get a lot more energy out of our fuel by the ability to oxidize, but we also leave a lot of burning embers around the mitochondria, a lot of oxidized material, which causes inflammation, burns Oxidation is also known by mechanics as rusting, and it's basically oxidation is burning or rusting. So the human body doesn't do a simple type of reduction. Reduction is the opposite of oxidation. Oxidation is adding an oxygen atom or taking away a hydrogen atom. Instead of adding the hydrogen atom back, the human body for reduction, the human body usually adds a full methyl group. So where does all that come out in terms of things to look at and connections that you might make in terms of your own labs, your own preventive state? One of the key places that it comes out is homocysteinuria or homocysteinemia, homocysteine, elevated levels of homocysteine in the blood. If you have elevated levels of homocysteine in the blood, a lot of people that that focus on prevention realize that that is a risk factor for heart disease. The reason for it is it's very much associated with the back to the body's inability to methylate. You can see here, you get a buildup of homocysteine if you're not able to, if your body's not able to methylate. Now, methyltransferase, other methylation types of MTHFR, for example, all of these are associated in methylating homocysteine to form methionine. You'll see related components, SAMs, S-adenyl cell methionine. And you'll also see that there's a lot of these things that are given, for example, for mental health issues, for other issues. Again, pardon me if it sounds like I'm jumping around, but what I'm trying to do is connect a few dots that a lot of people just haven't really connected, because the methylation process, as I mentioned before, most people think it's insignificant. Nobody argues that humans have a difference in their ability to methylate, but they argue about its significance. Others get very passionate about it. Others are very concerned about the relationship of failures to methylate and mental health related issues. We're going to cover an issue in just a minute. I'm going to go ahead and give a spoiler comment. We're going to talk about methylation and risk for eye disease, retinal disease. We actually, I'm going to show a few pictures out of a study where people that were having age-related eye disease, you remember AREDS, which is very much related to diabetes. This was escalated. It was increased, and the ophthalmologists were taking pictures of the back of the eyeball. They took people that had methylation problems, and we'll show that in just a minute, and actually gave them supplements. So the bottom line is they were showing how they improved retinal disease. So again, thank you for your interest. Thank you for your patience. If you've you're still here with me jumping around in terms of trying to connect a lot of dots. Age-related eye disease, retinal disease of diabetes, folic acid, methylation. Real quick, where do you get where do you get folate? You can supplement it. Usually that's with foods. If you supplement it, again, look for the difference between folic acid and folate. Now, just a comment. Why is this fairly? This is unusual, right? The diabetic eye disease, the retina disease, is only for people who've got full-blown type 2 diabetes. No. By the time you get a diagnosis of type 2 diabetes, 30% of us already have damage to our retina, our eyes. So that's not just very few people. If you look at the fact that by the time we're age 60, the majority of us have insulin resistance, then you start to connect the dots here in terms of this is not arcane, unusual stuff that you don't have to worry about. You probably have this, especially if you're 60 or above. If you're 50 or above, you're very likely to have some combination of these two issues. So again, I jumped through a lot of hoops, connected a lot of dots. Maybe the connections that I made were a little bit weak, but this is a slide where I want you to stop and think about it. How common is diabetic retinopathy? It's a lot more common than just diabetes. Number two, how common are methylation issues? 40%. 40% of us have a genetic variation in MTHFR. So let's go on. And so I've already covered this. This was one of these studies which shows, again, 30% of the people, by the time they had a diagnosis of type 2 diabetes, already had diabetic retinopathy. In other words, diabetic retinopathy is not just for diabetics, it's for people with insulin resistance. And hopefully, I'll clean this presentation up a little bit by the time we make a canned video on it. But again, I wanted to start getting some of this information out there. I was introduced to an ophthalmologist who's got a special interest in this space by James West, a common friend of ours. And this is the article where I wanted to show you some of those images. Basically, what they did was they took people that had diabetic retinopathy. They took people that had specific MTHFR problems and gave them a supplement. This supplement was a combination of AREDS, the age-related eye disease supplement. You know, that's mostly antioxidants and a combination of copper and zinc. The other thing in this medical food was L-methylfolate. So again, back to the connection between methylation and folate and more rapid or increased risk for diabetic eye disease. So this was basically, it's not a clinical trial, it's a preliminary report. It's basically a case survey. I mean, a case, it's a list of cases, a group of cases that they did. So they mentioned homocysteine. They also mentioned vitamin D as risk factors for this in terms of diabetic retinopathy and hypertensive retinopathy. So they're saying, look, we know that you've got increased risk for people with methylation problems. So we gave them food that contained L-methylfolate. These are high doses of L-methylfolate, for example, by the way, 2.7 milligrams or 3 milligrams. They're well above the RDA, the recommended daily allowance, but below most definitions of toxicity. So again, the components, as I mentioned before, a combination of the methylation supplements. So for example, when somebody has a homocysteine problem, you go back and you remember that high homocysteine or homocysteinemia indicates a problem with methylation. 40% of us have that. What I'll, excuse me, pardon my cough. I got a cough when I was at the AOSH, American Academy of Oral Systemic Health meeting this past weekend. Just now getting over it, but it's been painful. So back to the components of the foods that they gave, or the supplements that they gave. It was methylfolate and the other B vitamins. If you look on Amazon, for example, you can see Thorn Methyl Guard, several other different types of of methylation components. And all they are is the several different components of the B vitamin complex that have already been methylated. Then you really don't have to worry quite so much whether or not you're a, whether you have that 40% of that MTHFR problem that 40% of us have. So you see the vitamin B complex methylated here. You also see vitamin C, E. So that's the, and zinc, copper, cupric oxide. So those are the things associated with AREDS. So antioxidants and methylation components. As you see, this was the case series, and the vast majority of them have the same one that I have, MTHFR C677T, and again, that's the one where about 40% of us have. There are other types as well. As you see, this one is homozygous for A1298cc. These are variations of MTHFR. All of these patients had it. I'm just going to go over a couple of pictures and you can see that. So you see these red splotches in here. This was prior to supplementation, and you can see how those red splotches are going away. Let me give you, and that took a couple of years, by the way, for that to happen. You see the same thing here. You can also see it very well here. This is a cut version into looking at the actual density of the retinal tissue. Again, not nearly as dense and strong as it is post supplementation. Same here, more of the hemorrhagic spots from the retinopathy. And again, they had several others. Again, you can see them. I will do a more formal video. Again, if you've made it this far, I appreciate your interest. I'm going to back out now and see if we've got any questions or comments. We do. We've got Bob Kraft here. Thanks, guys, for making the comments. Again, we did a presentation earlier this week, and for some reason, the comments didn't come through. Jeffrey Ehlers, good morning, Doc. Bart Robinson, good morning. So Bart, the comments didn't show up earlier. Do we have any questions regarding this or other activities that we're doing? I don't see any. So I'm Amr Al-Gayar, hi from Germany. Again, I know this was a little bit of a disjointed type of presentation today. Please let me know if you have questions regarding. Here's the bottom line. Number one, consider the fact whether or not you have insulin resistance. Most of us by the time we're age 60 clearly have it. Number two, consider whether or not you have methylation problems. A lot of guys like Z-Dog don't think that's an issue, but I can tell you it is. It's an increased risk for some very important things like our vision. Number three, consider the fact that diabetic retinopathy does not wait until you get a diagnosis of diabetes. It's a problem with insulin resistance, pre-diabetes. Consider that. And then number four, it's like one of the comments that we got yesterday from one of our videos. I think all of this is very interesting to know about cardiovascular inflammation and some of the other things you teach about, Brewer. But I really want to know if I can do something about it. That's the point here. You actually can save your sight, retain your sight with supplementation. So like we say many, many times, supplementation, medication are important, but they can't get you out of a bad lifestyle. They can't. They cannot. They're not nearly as powerful as lifestyle components. But think about it. I supplement with it, and I actually will am looking to start offering this supplementation so people can know what they're getting. So Simon T. Rowe. Hi, Dr. Brewer. I got a 0 calcium score on Friday. Congratulations, Simon. That's a very good thing. Remind us how old you are. Joe Eos, Joe, Florida here. Good to talk to you, Joe. Joanne Kelleher, how about type 1 diabetes? Yes, the same problem. It's even more accelerated, usually with type 1 diabetes, because type 1 diabetes is usually far more severe. In fact, the vast majority of people with type 2 diabetes or insulin resistance will not ever need to get to insulin, especially if they do the proper lifestyle management. Let me just take a couple of minutes and share with you a little bit about what's going on with our webinar series. And then I'll go back and deal with some more questions. Hold on just a second. No, that's periodontal disease. That's not what we want. So we had our kickoff on our first webinar series yesterday. It was a great turnout. We had what, 15, 20 people. And here's the point that I can't remind us all enough of. We screwed up, meaning myself, me. We screwed up when we labeled this thing the webinar series, but we still continue to call it that. Here's why we screwed up. People don't realize that what we're doing is giving you access to some testing that Quest used to offer direct to consumer, the major one being the inflammation panel. We also are giving you access to OGTT, as well as an insulin survey. So what we do is you call in, you sign up for the webinar series, you get the inflammation panel, you get the OGTT, and you get the insulin survey. You get those results. Then we meet with a group of us and just go over what these mean, how to interpret that. What does it mean for you? Again, we talk about some of the key points behind it. Inflammation is something that was confirmed to be a big deal. I mean, even something like Time magazine, it's the secret killer. It's a surprising link between inflammation and heart attacks, cancer, Alzheimer's, and other disease, and what you can do to fight it. So Time magazine knew it was important enough to have a cover article on it. Back in 2004, the cardiology groups, the standards committees in medicine are still struggling with how to put that in the standards of medicine. Pardon me, just still got a bad cold, sorry. And I may have to cut this off early because I'm starting to sneeze and have some other problems, and I'm about to run out of water. But let's go back and deal with a few more questions before we do. SAR, how much methylfolate supplement? I think what they were saying was 15 to 20 milligrams. Let me, yeah, 2.7 milligrams and 3 milligrams respectively. When you read, if you look this article up and read it, there's several different brands. These brands have a very high level of methylfolate. Read up a little bit on methylfolate before you access those, because a lot of people will say they get hyper with methylfolate. They sometimes lose sleep. Others will say they go the opposite direction and actually get depressed. Chris Masterjohn has a couple of videos on the topic. But this group used the higher levels of methylfolate because of some of the issues unique to the eye and vision. Bart Robinson, Walter Ski, great question. I want to do the same thing with my doctor. I don't see, oh, okay. Walter Ski, I want to provide a video link to my primary care doctor to watch. Do you have one suggested video you have done that presents all of your facts on testing so that my doctor will take the time to review and understand? Walter, I wish I did. This is not an uncommon request. The bottom line is, though, I've got 600 videos now. We get way, as you saw today, we get way deep. And as you saw today, I demonstrated sometimes I don't, the presentation skills aren't the greatest. But the information is very important. It's critical to those of us who are in our middle ages and who are starting to suffer from chronic diseases. Prevention is so much better than a cure. My most popular video is how I reversed 20 years of plaque. If that's a standard doc, standards of medicine type doc, he or she may respond best to that video. It might shock him a little bit to realize that there are other ways to measure plaque, and he may be a little bit skeptical of CIMT. Again, I've got plenty of videos on that, but at least that video focuses on some of the things that that the docs that are practicing the standards of medicine are used to dealing with. For example, statins. It would give the devil its due in a couple of those videos about reversing plaque. Once you start on statins and your body's been statin naive your whole life, that is your most likely case to get actual reversal of plaque. And I was one of those cases. I do have a lot of docs that watch this channel, a lot of PAs, a lot of NPs, a lot of dentists. And again, I'm sorry, I don't have one place that they can go and see everything in a 5-minute time period. And again, you're talking, you're talking about people that are overworked. They're averaging 7 minutes per patient. To get them to slow down and look at 600 videos like this, good luck. One other thing I would say is, Walter, you may not have seen, I presented it a couple of times and I don't know, I don't have it immediately available, but here's the thing. I'm not beating up on primary care docs. I spent most of my career supervising, recruiting, training, working with primary care docs. I've been a corporate medical director for decades. And most of them come out of their training with a zeal and an interest for doing primary care and especially prevention. But they get frustrated. You know, the first 100 patients that you basically try to tell lose weight that don't do it, you sort of forget making that suggestion. But that's the doctor's perspective. They do surveys on this. For example, there was a survey done by the folks at Hopkins on the primary care docs in the nation and how much they knew and what they did about prediabetes. For example, they said that about 43% will give metformin for prediabetes, but less than a third of them will actually even refer a patient to intensive lifestyle care. So a couple of different points. Yes, they're used to using medications. You can do that very quickly. Yes, they're doing it for prediabetes, which you should do. In fact, 43% use of metformin for prediabetes is way, way low. So there ought to be more of that. In addition, obviously, lifestyle is king. It's by far more, it's 3 times more important than metformin. So you should be having 100% management of lifestyle. Lifestyle management takes a lot of time. So again, I hope this helps get you around to some of the perspective of why you're not going to see quite as much focus on prevention with your primary care doc. they're overworked. They've got a lot of stuff to do, and prevention is not a 7-minute turnaround kind of thing. Anyhow, maybe I've beat up on that too much. Ken Patu, would early retinopathy be seen in a dilated eye exam, or would the patient experience symptoms at that early stage? Very likely not to show any, great question, very likely not to show any symptoms, but yes, it would be seen by an ophthalmologist on eye exams, and it would be detected by most good optometrists as well. Simon T. Rowe, 48, not sure what that comment means. SAR dot, so how much methyl, okay, we talked about that. Steve Smith, what tests are recommended? I'm not sure what tests you're asking about for which situation. Simon Tiro, ex-smoker, low car, keep fit, but drink lots of beer. Well, I think there's a conversation going on in there, and I think I missed maybe some of the some of the first part. Again, Simon Tro, congratulations on your low calcium score. 1957 Cato. Hi, Dr. Brewer. It's hard to find PrevMed around here in Puerto Rico. It seems like we are in our own. Do you know who does it here? When I was chief medical officer for MDLIVE, we started looking around at developing a program in Puerto Rico. I have some familiarity with the market, the docs down there. What I would suggest is that you call Michelle or send Michelle an email, and we will talk about maybe some potential for providing some access. Simon T. Rowe, is low dose ramipril good for inflammation? Yes, it is. It's a great question. So you may wonder why, pardon me just a minute. Sorry about that. That's my little furry friend trying to get in. And if I don't let her in, she's going to be disrupting us with a lot of noise, scratching on the door. It was a great question about ramipril and inflammation. So you may wonder why we use ramipril. Number one, it's been associated with, it really helps with diabetic and pre-diabetic chronic diseases. There's incontrovertible, tons and tons of scientific evidence around that space. Now, here's what happens. You remember I've said multiple times, look, I don't really use statins so much for LDL. I use statins to decrease inflammation. Same thing with ramipril and the other ACE inhibitors. They have what's also called a side reaction or an unintended reaction. Not only do they drop the blood pressure, but they have another reaction, they decrease inflammation. So if you put statins together with ACE inhibitors, it's not an additive effect, it's a multiplicative effect of decreasing inflammation in your cardiovascular tree, in your arteries. So that's why ramipril is such a go-to medication for blood pressure. In fact, if we have somebody who's got inflammation going on, but very little blood, but not very much blood pressure or high blood pressure, we'll still try to push it just a little bit so we can add just a little of ramipril into that if they need it. Martin Bradshaw, 46-year-old male, exercise regularly, keto, lots of cruciferous vegetables, intermittent fasting, IGF-1 values consistently low over the past 5 years. What is your opinion on peptides? I hate to say it, Martin, but I really don't have one. But it's thank you for making me aware of the question. Walter Ski, thanks. Might be a great video for the future to do what? Summarizes your testing backing it up with the studies. My doctor likes to know the studies behind the latest treatment idea. Well, Walter, I mean, that's a really good point. This is back to the issue of how does you get your information to your doc? tell him to buy the inflammation course. It's 2 hours, and it goes into the exact testing that we're talking about for inflammation, and it also goes into the support behind the testing. Lewis, is vitamin C supplement a good supplement to reverse plaque? That gets back to the Linus Pauling theory. I think vitamin C is clearly an antioxidant, and from that perspective, it helps. The logic behind the Linus Pauling theory is good logic, but the science tends to fall apart there. The evidence behind vitamin C alone being a big deal is just not there. Steve Smith, what test will show how well we methylate? You could get a full-blown genetic study. As many of you know, I've worked for and with a genetics lab for the past 5 years, so I get my testing for free. You can get methylation, MTHFR testing with genetics, but there's a very simple, very, very easy way to get a great clue, and that is homocysteine. You might have missed it when I mentioned it earlier, and again, it seemed like I was jumping around a lot. I didn't cover the details maybe clearly enough. But when you have high homocysteinemia, high homocysteine in your blood, it's quite often due to having a methylation problem. So let me just go back and make a couple of, just give you an update on a couple of things. We talked about the course just a minute ago, PrevMed. So a couple of things about the courses and some of the other services that we have available. Maybe I'm not going to be able to get in there. Well, maybe I won't be able to show that to you today. Oh, here we go. No, won't be able to show it to you. Let me just give you a brief verbal breakdown. We did have the CIMT tour. We've got a couple of other places coming up. Well, and the one in Anaheim, 3 or 4 weeks ago, we had 31 people get a CIMT. I think about a dozen of them had some problems on their CIMT. They had significant plaque. David will be in, I think, San Antonio, like February 15. I think he's going to Detroit, March or April. We've got one other place. I'll be sending that information out. But again, if you'd like to get on that list, just go to cardiorisk.us/forward. When you go to cardiorisk.us/forward, you can sign up .us/forward. You can sign up to get on a list to find out where we will be doing a CIMT, or where David and Todd will be coming around to give you a CIMT. David gives about a half day. We're probably going to increase it to a full day presentation. I come in by video, Todd comes in by video. And again, most importantly, you can get your CIMT at a town near you. You go in here, cardiorisk.us/forward, and then you can sign up, give your first name, last name, and list the cities where you'd like for us to come. Now, one that I didn't mention yet is the event that we're doing. November 9th and 10th, we've got a couple of dozen people signed up for it. We've got a large room, so if others are interested, we can certainly accommodate. A couple of dozen is a good number for the way we do this. It's basically, we will get all of the labs. This is a great way to go ahead and get a complete evaluation within just a couple of days. You sign up, you get all of the labs, you bring those labs to excuse me just a minute, Clyde. You bring all of those labs to the event, and we go over your labs as well as do a 2-day boot camp on what is what's going on in prevention. We've got a third, speaking of courses, we've got a third course coming out in about 2 weeks. It's on plaque, how to measure plaque, how to detect it, how to screen for it, how to track it after you start dealing with your heart attack and stroke risk. We also have a book coming out. Todd and I are doing a book. I wrote about 80% of it. It's CIMT and the other ways of measuring plaque, looking at it from a doctor's perspective, from a doctor talking to a patient. So again, both a course on that topic and a book coming out over the next month or so. I think that's going to cover most of our announcements. Oh, yeah, and I talked about the webinar. The webinar is becoming a great place for people to if you don't want to pay $1,000 to see me or a prevention doc, you can get in fairly, much less expensively, get some of the labs included in a much smaller price point, and start finding out, do you need to invest further? So let me go back to handle some more comments and then I'll sign off. Steve Sapel. Steve, I hope I'm pronouncing that correctly. Hi, Doc. What's your take on K2 causing calcification in artery walls? I don't think that K2 causes calcification in artery walls. I think it, there's some case to be made that it actually decreases it, but that's not my reason. The reason for my interest in K2, the reason for my interest in K2 is, oxidation and of osteocalcin and some other enzymes that are involved in that process, but they're also very much linked to insulin resistance. We've got a couple of other comments, but again, sorry folks, my voice is not doing very well. Hopefully I'll be well by next week. Thank you very much for your interest.